My name is Norman Putzki. I'm the Senior Vice President and Global Head of Development for Neuroscience and Gene Therapy here in Novartis. It's my pleasure today to discuss with you the data that we presented at the MDA recently regarding our gene therapy for spinal muscular atrophy. In SMA, there's just one fundamental biology that is underlying the clinical manifestation of essentially muscle weakness and muscular atrophy, and that's the deficit in the SMN1 gene. So if you miss that gene, or there is a deficit, then your muscles will not grow and actually weaken over time, and you will see atrophy. And that is the fundamental principle across the entire spectrum of SMA, actually. So it's important to realize that this biology is similar across all stages of SMA that has been described previously. The gene that impacts on what type or stage of SMA you actually have is the SM2 gene that can partially compensate for some of the dysfunctioning of the SMN1 gene, but not fully, because the SMN1 gene is the strongest gene, so to speak, needed to produce the SMN protein. So that I think that the biology is really fascinating when you think about it, because if you have a gene therapy that is targeted directly at the SMN1 gene, like our gene therapy, that can really deliver a functioning copy of an SMN1 gene, then you can fix the basic foundational pathology across the entire spectrum of SMA. And I think that's the fascinating opportunity that you have with a targeted one-time gene therapy for treatment across the entire spectrum of SMA. We have been on this journey of developing a gene therapy or gene therapies for SMA now for quite a long time. And most recently, we presented the data for our intrathecal gene therapy that we developed for children and adolescents in the age group of 2 to 18. And that's a really broad spectrum of SMA patients, and different from the original data that we generated for our IV gene therapy, where essentially this medicine was tested in the newborns who had the most aggressive forms of SMA. And we have seen quite transformative data when this medicine became available. So at that point, we only had studied the most aggressive forms mostly in those babies, essentially. So when the medicine became available, there were already a lot of patients out there who were more advanced and who did not have the most aggressive form of the disease. So literally thousands of patients who could not be served with a one-time gene therapy because there were other types of SMA that were not previously tested. So we had to do an additional development program to have a gene therapy that targets the same underlying biology across a broader spectrum than it was originally tested. Now, the IV treatment in the newborns is weight-based. So there are some limitations in terms of dosages that you can actually provide to patients. So there was a need to come up with a different regimen for children who are heavier and older and in the other types of SMA outside of the actual newborns. So we developed a flat dose, one-time intrathecal gene therapy to serve all these patients across the broader spectrum of SMA. And then at the end of last year, we published the top-line data, and then most recently released more data at the MDA conference for this broad spectrum of SMA patients that we've studied in the STEER study and also in the STRENGTH study. The STEER study is a pivotal study for this age group of 2 to just below 18 years old. STRENGTH was studied in the same age range, but not in a placebo-controlled design, just an open-label design. So both studies complement each other. So in the STEER study, we demonstrated the superiority of OAV101 IT over a sham control, where patients received a sham intrathecal injections, and we followed those. And in STRENGTH, we had 27 patients who were followed after they had discontinued previous treatments with chronic treatments for SMA, like nusinersen and risdiplam, and then they were switched to receive the OAV101 IT treatment. So at both data sets, they complement each other. The one data set was really meant to demonstrate that we have a meaningful improvement over the sham control in the STEER study. And then in the STRENGTH study, it's an additional data set for safety because we assume that once the drug is available, that many patients will decide to discontinue their previous chronic treatments and instead receive a one-time gene therapy. So that's additional safety data that was necessary for the community to understand if this can be pursued out in clinical practice. We now have long-term follow-up in several data sets actually available from children that were originally exposed. We also have ongoing long-term follow-up for those patients that have received the IG treatment. But that's, of course, limited because that's relatively fresh data. So when you think about the biology of the disease, the most important factor that will determine how well you respond to the gene therapy is how early you receive it. So in that sense, time to needle, that's the most important factor because it will disrupt the time that you will lose neurons, motor neurons, I think, at the end of the day. So your capacity that you can build over time is higher the earlier you are treatment. So I think this is where it's important to realize that this is for the newborns, for the aggressive forms. That's the best stage to treat is really as early as possible. And the long-term data show that you see kids growing up, many of them achieve normal motor milestones. You see disease stabilization for those who received it in the earlier stages. And this is also what we could demonstrate then for the later stage patients in the STEER study. And then also in the strength study, although it was focused on safety, you see motor improvement that is better than the sham control. It's statistically significant, it's clinically meaningful. And you also see in patients who had previously received risdiplam or nusinersen and then switched after many years of treatment of these other diseases, that they actually could not only be treated safely, but you also saw disease stabilization and motor improvement over the follow-up period. In the STEER study, we saw improvement on the gold standard scale that's being used, the Hammersmith scale, over the sham IT control. So what we saw was a 2.39 improvement on the Hammersmith scale, which means that there is improvement of various domains of motor functioning. And in the IT sham control, there was a 0.51 improvement on the scale. So you see there is a close to 2 points difference on the scale. If you ask yourself, what does it mean? 2 point difference. And when you look at the scale has certain categories where you can either rate 0, 1, or 2, or 1 or 2, which basically means that you have an improvement either from not being able to perform a certain task at all to full recovery, or you improve from not being able to perform the task at all to partial improvement. So it gives you some idea what the point categories may mean on a group level, not on an individual patient level, of course. And this is, I think that's what substantiates that the difference that we see in terms of improvement is something that is clinically meaningful. Here, Novartis Neuroscience is one of the core therapeutic areas, and we have 10 programs in the clinic. We focus on neuroimmunology, genetic medicines, particularly in the field of neuromuscular disease, and then the last one is neurodegeneration. I think I'm really happy how far we have come with genetic medicines in the neuromuscular space, and we will continue to focus on this. We have several platforms now available, and we will expand with our efforts to improve the lives of patients with neuromuscular disease beyond SMA. We're excited about what we've seen now with the STEER and strength study, and we will do our best to make this new medicine available to patients as fast as possible. So we're now in the regulatory process. So I hope I will soon be able to announce more to that end.